Ladies and gentlemen, it's a great personal pleasure for me at the start of my term as chairman of the British Journal of Urology International to be able to introduce this year's BJUI guest lecturer. He is, I'm sure, already known to many of you in the room as an outstandingly gifted technical surgeon, as a great teacher, and as I found out last night, a very entertaining and affable dinner companion. Having trained in a variety of urological centres around Europe, including the Institute in London, Hein van Poppel was appointed Professor of Urology in Leuven in 1993. And I think it's true to say that since that time, he's worked tirelessly to improve the quality of care for urological patients, especially those with urological cancers. He is a member of countless international urological societies, too numerous to list here this morning. But he also holds membership of the American Association of Genitourinary Surgeons. In 2009, was appointed President of the Belgian Association of Urology. He has over 500 peer-reviewed papers, but is perhaps best known to many for his educational activities, particularly as director of the European School of Urology, and most recently as chairman of the educational office of the EAU. He remains active in a variety of urological areas. He's a reviewer for some 27 international journals. He is an honorary fellow of associations as diverse as the Netherlands, Romania, and China, many of whom have given them their highest awards. It is indeed a great pleasure and honour that he's come here today to deliver this BJUI lecture.
Thank you, Krishna, for this nice introduction after the nice evening that we had together, where I was very pleased to meet you, and we have already become friends. It's really an honor for me that I can have this opportunity to talk on one of my babies. This is the place of surgery in high-risk and locally advanced prostate cancer. I think that next to partial nephrectomy, this is one of the issues that interested me most during my career. And I need to thank the people of BAUS, the people of the BJUI International. We have met with the editor-in-chief many years ago, in the early 2000s. He was in Leuven performing the first robot-assisted radical prostatectomy with Shamim, and then I was pleased to come to GUIS in 2008 as a visiting professor also to perform some surgeries. And you see that actually Prokaydas Gupta didn't change a lot. Maybe there's the right hand in 2008 to show his stump, and in 2015 it's the left one. Also, I want to thank David Quinlan and other people, the trustees, who have given me the chance to talk on this topic today. And why do I feel it is important? It's maybe even more important in the UK, where I think that still a lot of patients with localized and certainly with locally advanced prostate cancer are choosing to get radiotherapy and hormones. Although we realize that which patients do they die from prostate cancer? Not the vast majority that we have been operated on for years with early prostate cancer, with low Gleason grades or scores. But those who die are, of course, the metastatic prostate cancer patients on the one hand, on the other hand, those with massive lymph node disease, but also the high-risk localized prostate cancer patients and the locally advanced. This is the category of patients where we need to find out which is the optimal treatment. And you know we have no randomized trials, so we need to just look on what we have achieved today in retrospective and historical series. But these patients indeed deserve the best possible treatment. They will not all die from prostate cancer, as you will see, but this is the group of patients where we can really change their outcome if we treat them well. Problem is, of course, the definition of high-risk prostate cancer. And you see the progression-free probability can vary between 35 and 76% looking at the definition. Is it just a high PSA? Is it just a high local stage? Is it just a high Gleason score? Or is it a combination of these three factors? So I would say there is, even in high-risk prostate cancer, there's a low-risk, high-risk, there's an intermediate risk, high risk, and there's the really high risk prostate cancer patient. And these are the guys that are prone to die from the disease. And this is something that I really disliked many years ago, where you see that localized prostate cancer could be treated with radical prostatectomy, radiotherapy, or active surveillance. But when it comes to high risk and locally advanced, there was radiotherapy and hormones was delivered also on indication of urologists and not only of radiotherapists. And why is that? Surgery was not applied so often because we ended up with positive surgical margins. We had positive nodes. Patients needed to have secondary treatment with radiotherapy or hormones. So we were not very much in favor of really pursuing surgery in these cases. Although I believe surgery is probably the best. Why? Simply because also before submitting a patient to radiotherapy or surgery, we know that we can overgrade tumors. This is Gleason scores 8 to 10 in radical prostatectomy patients. And you see, well, they had Gleason scores on the biopsy of poorly differentiated tumors. 45% of the patients had a Gleason score of 7 or less in the radical prostatectomy specimen. So if you would direct these patients to radiotherapy, they will not be optimally treated because they can easily be cured by surgery. On the other hand, other studies have shown that about 1/3 of high-risk prostate cancer patients with a Gleason score on the biopsy of more than 8 were overgraded. And the same actually holds for the pathology that we find. How many of the patients that we believe have T3B or T3A tumors end up with positive surgical margins or with nodal disease? And this is serious from many different authors. And if you look, this is finally the number of patients that have PT3, just extracapsular extension without invasion of the seminal vesicles, and those who have negative surgical margins. And you see it's really a fairly big amount of patients that are cured by surgery alone. So we have been overgrading and overstaging clinically a number of patients and did not offer surgery to them because we believed they had higher stages or higher grades of the disease. Now, there is a big evolution in the treatment of prostate cancer. We know today that radical prostatectomy is not needed for low-risk localized prostate cancer. Although all of us, we have been treating these patients like Pathology for many, many years and over-treated many of them. Locally advanced prostate cancer, now today, surgery is the preferred option. Indeed, a certain percentage, as I just showed you, it is not so bad and can be cured with surgery alone. And then probably the only patients that really benefit, the only patients in which we will extend their survival, are those with high-risk prostate cancer. And they really will benefit from surgery the most. If we look at the guidelines of the EAU, there is still that patients with low and intermediate risk localized prostate cancer are good candidates for radical prostatectomy. I think that many of us today put these patients on active surveillance. And optional, there are the selected patients with low volume, high risk localized disease, but more importantly, highly selected patients with very high risk localized or locally advanced disease, even with limited nodal disease, but of course in the context of a multi-modality treatment, and that's the key issue. Now, if I look at my own series, you see that about 2004, I was myself personally performing about 250 radicals a year, and this has come down to 120 today. And I can tell you that it's just patients that we overtreated for so many, many years, and about 1 out of 2 patients that I do surgery on today are high-risk or locally advanced prostate cancer patients. And it's the same what happens in tertiary, in high-volume centers. This is Hamburg and this Memorial. where you see that the number of high-risk patients in the entire radical prostatectomy population is increasing, while the low risk have come down, the intermediate risk being about equal. So even today in screened populations, high-risk prostate cancer accounts for today for about 20% of radical prostatectomy patients, and I believe today that's even more. But what happens in non-high volume centers? And you see in dark blue is the patients that have been treated with hormones. In light blue, you see that's the patients that have been treated with a radical prostatectomy. And you see that in the low-risk patients, we are really over-treating patients with radical prostatectomy, while in the high-risk patients, we are doing hormones or radiotherapy. Exactly what we should not do. Low-risk prostate cancer is treated actively, while high-risk prostate cancer patients is often treated conservatively. And again, this is the evolution of high-risk prostate cancer patients between 1990 and 2007. And you see that in the general community, there is an increasing number over the years of men with high-risk localized disease are treated with androgen deprivation therapy. And this is absolutely under treatment because this treatment does not cure any patient. So, since there are no randomized trials, when we treat actively these patients with high-risk disease, we just have retrospective evidence that mostly comes from high-volume centers, and we know that there is high rates of multimodal treatments. Now, I want to argue why I would not prefer to go for radiotherapy and hormones, but rather for surgery in a first stage. And the first argument is that we know that radiotherapy, of course, works, and we know that it works better if we combine it with hormones. But you need to give 3 years of hormone treatment. And radiotherapists that want to convince patients about this multimodal treatment with radiotherapy and hormones realize that. But do they realize what they actually do? What's the cardiovascular death rate in patients that have been treated during 36 months with androgen deprivation therapy compared to 18,000 that had no androgen deprivation therapy? And you see that there in androgen deprivation therapy there's a 1.2-fold increase of cardiovascular death. Radiotherapists realize that, and they want to cut down on the number of months of giving hormones. 3 years is the Bolla trial initially. Then Bolla tried to have 6 months instead of 3 years, and he saw that it was inferior. We have tried 18 months compared to 3 years, and it seemed to be equal. 4 months is inferior to 1 year. So the debate is still ongoing, but probably if you want to optimize your radiotherapy treatment in these patients, you need to give them hormone treatment for 12 to 18 months. But even the short duration, I think that the negative impact of hormones is pretty early, because this is patients that only had 4.1 months of androgen deprivation therapy. And certainly in this category, which is the majority of patients that we see above 65 years, you see 5.5% cardiovascular death if they had hormones, and only 2% if they did not have hormones. So it's more than double when you give hormones for only 4 months. And this is the most recent analysis from Bosco. This is a meta-analysis. 8 observational studies looking at the relative risk. With androgen deprivation therapy, the risk ratio of non-fatal cardiovascular disease is 1.38. Myocardial infarction, 57. And severe or stroke, 51. So we know that low testosterone increases LDL cholesterol and triglycerides, and that's probably the mechanism that is behind this cardiovascular disease fact linked to the androgen deprivation therapy. Okay, that's the hormones that you need to give if you treat high-risk prostate cancer patients with radiotherapy. On the other hand, there's the toxicity of the radiotherapy. We all know the acute genitourinary and GI toxicity. It's minor, mostly after 6 months to 3 months it subsides. But we as urologists know very well these late genitourinary complications with bleeding, rectal bleeding, with radiocystitis, hyperbaric oxygen, and some of these patients need finally to undergo urinary diversions because of the problems caused by the radiotherapy. It's a minority of patients, but we all know how severe this late GU toxicity can be. The fatigue from IMRT, the modern IMRT, has recently been also very well defined. And finally, there's secondary bladder and rectal cancers that these patients are likely to develop in a minority of them. And then finally, is it better to give radiotherapy to spare the patient functional problems after the treatment? And this is the Resnick study that you all know, and they've been looking at between the prostate cancer diagnosed many, many years ago, and they look at 15 years disease-specific functional outcome in this number of radical prostatectomies versus external beam radiotherapy. And this is about urinary function, sexual function, and bowel function. And you see that after 15 years, there is no significant advantage for radiotherapy on these three functions. So even trying to spare the patient the initial complications he can have concerning sexual function and urinary function after radical prostatectomy, you see that in the end, there is no advantage for radiotherapy over radical prostatectomy. And then finally, this is a more recent study from the Canadians. They looked at radical prostatectomy and radiotherapy treated patients and looked at hospital admissions, rectal and anal procedures, open surgical procedures, and secondary malignancies. Admittedly, the radical prostatectomy patients were younger and had fewer comorbidities, but if you look at this, in blue is the result for radiotherapy. And you see they had much more hospital admissions, hospital admission longer than 1 day. Minimally invasive urological procedures, initially there were more after radical prostatectomy, but in the end it's the same. Anorectal procedures with radiotherapy and open surgical procedures needed to cope with the complications of radiotherapy are significantly higher in the radiotherapy-treated patients. Now, if we know all that, would we then give surgery or radiation for high-risk prostate cancer patients? We know that if we give radiotherapy, we need hormones. There's the early and the late radiotoxicity. There's a risk of second cancers. Functionally, it's not better at long term. And late local tumor complications occur. Let's then maybe look at the oncological results in the end. Can we compare? There's no randomized studies. But what we have from the literature, for instance, is this. D'Amico, a radiation oncologist looking at the results of radical prostatectomy versus radiotherapy when it comes to cancer-specific mortality. This is the years after radical prostatectomy, and you see whether you do radical prostatectomy or radiotherapy. Cancer-specific mortality is the same. Probably when you do active surveillance, it would be exactly the same as well. In the intermediate, there starts to be a disadvantage for radiotherapy. And in the high risk, I think it's very obvious that the results are poorer and that more patients die from prostate cancer when they were initially treated with radiotherapy. This is 10-year cancer-specific mortality. Again, high-risk prostate cancer patients. The high risks in the CAT score are on this side. This is low-risk disease. Whatever you do, there's no difference. But when it comes to high-risk patients, you see that radical prostatectomy outperforms radiotherapy and certainly outperforms androgen deprivation therapy. So the greatest differences, again, are in the high-risk prostate cancer patients. A disadvantage or a criticism that the study got is that radiotherapy in these cases was not always adjuncted with androgen deprivation therapy. So this is indeed suboptimal radiotherapy, but still, radical prostatectomy does better. Zelewski, again, radiation oncologist looking at 8-year freedom of metastasis. This is the CAT preoperative 5-year recurrence-free probability. The low-risk patients are here, the high-risk patients are there. And again, you see there's a statistically significant advantage for radical prostatectomy for the occurrence of metastatic disease. And this is not old-fashioned radiotherapy. This is 81 to 86 gray. So this is modern radiotherapy delivered by experts. And you see that, again, radical prostatectomy is outperforming modern radiotherapy. One disadvantage in this study is that salvage therapy was earlier delivered in the radical prostatectomy patients because radiation oncologists mostly they fail their treatment, but will start adjuvant treatment measures like hormonal treatment later than we urologists are inclined to deliver radiotherapy as a salvage measure after radical prostatectomy. But maybe the most important data come from this study that you know is the Swedish registry. And this is looking at radiotherapy versus radical prostatectomy treated patients by the group of Wiklund published. And there is prostate cancer mortality and there is non-prostate cancer mortality. And you see, if you look at the non-prostate cancer mortality here, that's about the same. But if you look at the prostate cancer mortality in patients risk group 4, this is N plus T4 or PSA above 50. That's the same. But look at those patients. This is the D'Amico group 1, risk group 2, and risk group 3. And you see that the prostate cancer mortality after 15 years, and this is what you need if you want to evaluate the effect of a treatment in prostate cancer, you see that the mortality is about double of what you have in patients that were initially treated for high-risk prostate cancer with radiotherapy or with surgery. And then finally, 2014, Petrilli, meta-analysis, radical prostatectomy versus radiotherapy for high-risk prostate cancer patients, 17 studies, overall survival, prostate cancer-specific survival after surgery or radiotherapy. And radical prostatectomy gives improved overall survival, statistically significant, prostate cancer-specific mortality, and even non-prostate cancer-specific mortality compared to radiotherapy. And I think this is the strongest meta-analysis evidence that we have today. And these are the results of Petrilli, where you see there's an advantage in the different studies for overall survival. And the same is actually confirmed for prostate cancer-specific mortality. So if you treat your patient with radiotherapy initially, you probably are not delivering the optimal treatment he could get. So why do I believe that radical prostatectomy should rather be given in high risk rather than radiotherapy and hormones? We have shown good overall survival, excellent cancer-specific survival in monotherapy or in multimodal treatment. At least 20% of the patients do not have that adverse pathology that we anticipate from the biopsies. We avoid early and late radiotherapy toxicity and second cancers. You get optimal local control, and I forgot to mention this, but you avoid lower urinary tract symptoms and late local complications. You have a clear-cut situation after radical prostatectomy. You have PSA like no other tumor marker after radical prostatectomy that will indicate the possible need for adjuvant or salvage therapies, be it radiotherapy or hormones. And indeed, you obviate the need of hormone treatment, or you can postpone it. And I've shown that even short-lived hormone therapy is increasing cardiovascular morbidity and death. So what do we do with the really high-risk prostate cancer patients? That's the T3B with a PSA of 75, no nodal disease, a high PSA, and a high Gleason score 8 or more. I believe that if you think that you can take the tumor out completely and achieve negative surgical margins, and probably your finger, and today MRI can help you in assessing this, start with surgery. You look at your pathology, what's my PT stage, what's my pathological Gleason score, what are the margins and the nodes. You look at your postoperative PSA. You look at the continence recovery. Maybe the wish of the patient to recover his erectile function after 8 or 9 months, and his preferences. And then you consider eventual adjuvant or salvage radiotherapy or hormones. When the patient with high-risk prostate cancer is talking to you, don't tell him that radical prostatectomy will cure him. He needs to know that he is prone to adjuvant or salvage treatment measures in a very high percentage, and I think this must be estimated today at about 60 to 65%. So to conclude, a multimodal approach is key in high-risk prostate cancer, but initial surgery offers the possibility of tailoring eventual adjuvant or salvage treatment measures. And then the eternal last sentence: despite evidences reporting a more favorable outcome for surgically treated patients as compared to those treated with radiotherapy, a prospective randomized trial remains needed. I'm not sure this will ever be done, and the evidence we have is the evidence that I have shown you during this presentation. So for the time being, there's no randomized trial. What's the optimal treatment? I think surgery is the most important first step. In resectable high-risk disease, for me, radiotherapy is there in an adjuvant or a salvage setting. And I will try to postpone hormonal treatment as long as possible, also in later stages of the disease. I thank you for your kind attention.
Thank you very much, Hein, for that very erudite, clear and well-argued case. I say personally it's wonderful to hear a presentation on localized prostate cancer without hearing the word robot, except once in the introduction. But thank you all very much. And that concludes this session.